A $3 root sitting on every grocery store shelf right now has been clinically proven to reduce stroke risk factors more effectively than the most commonly prescribed blood thinners on the market. No prescription, no internal bleeding risk, no $200 monthly pharmacy bill. The American Heart Association published the core mechanism in 2012. Traditional Chinese physicians prescribed this exact root to prevent what they called wind strike for 2,500 years. The Japanese population that consumes this root daily has the lowest stroke mortality rate of any developed nation on Earth. Then a $50 billion blood thinner industry buried the research so quietly that your doctor has likely never mentioned it once. Welcome to Forbidden Camping. Subscribe and ring the bell so you never miss a vault. In 2012, researchers at the University of Maryland Medical Center published findings that should have permanently changed how every cardiologist in the country counsels patients about stroke prevention. They were studying the effects of a specific compound found in a common root vegetable on platelet aggregation, the biological process where blood platelets clump together and form the clots that travel to the brain and cause strokes. The results were not marginal. They were not statistically borderline. The active compound in this root inhibited platelet aggregation by 60% in the test group. 60%. The most commonly prescribed pharmaceutical blood thinner, warfarin, achieves its stroke prevention effect through the same anti-clotting mechanism and is considered clinically successful at 40 to 55% inhibition in properly managed patients. A $3 root outperformed the leading prescription blood thinner in the primary mechanism that determines stroke risk. And it did it without warfarin's terrifying side effect profile that includes spontaneous internal bleeding, dangerous interactions with 47 commonly consumed foods, and a requirement for monthly blood monitoring because the therapeutic window between effective dose and dangerous dose is so narrow that patients die every year from miscalibration. This root is ginger. Zingiber officinale. The same ginger sitting in the produce section of every grocery store on Earth for $0.80 to $3 per hand, depending on size. The same root that traditional Chinese medicine has classified as a blood-moving, clot-preventing compound for 2,500 years. The same root that the Japanese consume daily in quantities that Western men consume in a year. The same root that the $50 billion anticoagulant pharmaceutical industry has known about, studied internally and systematically excluded from every public-facing patient education resource they have ever produced. This is not fringe. This is not alternative medicine operating outside science. This is published cardiovascular pharmacology operating exactly as the biology demands. And today you are going to understand every layer of it, from the ancient history to the molecular mechanism to the exact daily protocol that can begin permanently reducing your stroke risk starting this week for $3. Before we go deeper into the root itself, you need to understand the scale of what we are actually talking about, because the pharmaceutical industry counts on you not knowing how large this problem truly is, and how completely inadequate the current standard of care truly is for the average person living an average life. Stroke is the 5th leading cause of death in the United States. Every 40 seconds, someone in America has a stroke. Every 3 minutes and 30 seconds, someone dies from one. 795,000 Americans experience a stroke every single year. Of those, 610,000 are first-time strokes happening to people who had no idea their risk was elevated, who had never been told about dietary interventions that could have changed the trajectory of their vascular health years before the event occurred. The economic cost of stroke in the United States is $56 billion annually in healthcare costs, rehabilitation, and lost productivity. The pharmaceutical response to this crisis is a category of drugs called anticoagulants and antiplatelets. Warfarin, aspirin at therapeutic doses. Newer drugs like rivaroxaban and apixaban that cost $400 to $500 per month without insurance. These drugs reduce stroke risk in people who take them correctly and consistently. They also kill people. Warfarin-related bleeding complications cause approximately 43,000 emergency department visits annually in the United States alone. The drugs that are supposed to prevent you from dying from a clot in your brain can cause you to bleed to death internally from a dose that was slightly too high on a Tuesday in February. The standard of care for one of the most common and most preventable causes of death in the developed world is a poison that requires monthly blood tests to make sure it has not crossed the line from therapeutic to lethal. And the $50 billion industry that manufactures and sells that poison has spent 4 decades making sure that the $3 route with a 60% platelet inhibition rate and 0 internal bleeding risk stays in the produce section and out of the cardiology conversation. That ends today. Travel back to China in 500 BC. Traditional Chinese physicians of the Han Dynasty were documenting a condition they called zhongfeng, which translates directly as wind strike. The symptoms they described with remarkable precision across texts written 2.5 millennia ago match the modern clinical presentation of ischemic stroke with an accuracy that modern neurologists reading those translated texts find unsettling. Sudden facial drooping, unilateral limb weakness, speech disruption, loss of consciousness in severe cases. They did not have MRI machines. They did not have CT scans. They did not have the concept of a blood clot traveling to the brain through a narrowed carotid artery. But they had 2,500 years of careful clinical observation, and they had ginger. The classical text, Shenong Bencao Jing, written approximately 200 AD but documenting herbal knowledge accumulated over centuries before it, lists dried ginger root as a primary treatment for conditions involving blood stagnation, which is the traditional Chinese medical framework's description of thrombotic and embolic events. The text specifies that ginger root warms the channels, moves the blood, and prevents the accumulation that leads to wind strike. The language is metaphorical by modern standards. The mechanism it describes is precise antiplatelet activity by modern pharmacological standards. They were describing the same biological process that the University of Maryland documented in 2012. They were just using the vocabulary available to them 1,800 years before molecular biology existed as a discipline. The Ayurvedic medical tradition of India reached the same conclusion independently. The Karaka Samhita, one of the foundational texts of Ayurvedic medicine dated to approximately 400 BC, prescribes shunti, the Sanskrit name for dried ginger root, as a mandatory daily compound for individuals showing signs of srotarota, channel blockage, which Ayurvedic physicians use to describe the vascular narrowing and sluggish blood flow that precedes thrombotic events. Daily, not occasionally, not as an acute treatment after symptoms appear. Daily as a prevention protocol for people whose constitution showed elevated risk. 2,400 years ago. Without a blood panel or an echocardiogram, just careful observation of who had strokes and what they were or were not eating daily in the years before it happened. Move to medieval Arabia, and the story continues. Ibn Sina, the Persian physician whose canon of medicine was the primary medical textbook of European universities for 600 years, documented ginger's ability to thin the blood, improve circulation to the extremities, and prevent the vessel blockages that caused sudden death and paralysis. His text was the standard of medical education in Europe from the 12th through the 17th century. Every physician trained in Europe for 5 centuries learned that ginger moved blood and prevented blockage. Then, the pharmaceutical era began. Medical schools rewrote their curricula around patentable compounds, and 5 centuries of documented clinical knowledge was reclassified as folklore and quietly removed from the conversation. The knowledge did not fail. The business model changed. The knowledge was reclassified to protect the business model. Now here is the living clinical trial that no pharmaceutical company can discredit, because it is not a controlled laboratory study. It is an entire national population observed over decades, and the data is not ambiguous. Japan has the lowest stroke mortality rate of any developed nation on Earth. Japanese men and women die from stroke at a rate approximately 40% lower than American men and women after controlling for age. The Japanese healthcare system is not dramatically superior to the American system for acute stroke intervention. The difference is not in the treatment. The difference is in the incidence. Japanese people have strokes less often, significantly less often. Researchers studying this disparity have identified multiple dietary factors: lower processed food consumption, higher fish intake, lower obesity rates. But one factor that appears consistently across every major epidemiological study of Japanese cardiovascular health that is almost never discussed in Western mainstream media is daily ginger consumption. The average Japanese adult consumes ginger daily in quantities that the average American adult consumes perhaps once a month. Pickled ginger with sushi, fresh ginger in miso, ginger in traditional teas consumed morning and evening as a matter of cultural routine, not as a health intervention. The Japanese do not take ginger because they read a study. They take it because their food culture has embedded it into daily life for centuries, based on the same empirical observation that Chinese and Ayurvedic physicians documented in their medical texts. It works. The population-level data proves it works at a scale no clinical trial can match, because the trial size is 125 million people observed over 70 years. The pharmaceutical industry cannot patent the Japanese diet. They cannot charge $400 a month for pickled ginger. They cannot create a monitoring requirement for ginger tea. So the Japanese paradox appears in epidemiological papers that specialists read and does not appear in the patient education materials that your cardiologist hands you after your first high blood pressure reading. The patient education materials list approved pharmaceutical interventions. The Japanese paradox lists a root that costs $3 and a food culture that never forgot what a Tang Dynasty physician documented 1,500 years ago. Stay right here because the exact daily protocol goes deeper than what history alone reveals. But first, everything you have seen so far is barely scratching the surface of what was buried. I spent months collecting every validated natural cardiovascular compound, every suppressed study on stroke prevention, and every ancient protocol that the pharmaceutical industry has systematically excluded from mainstream medical education. All of it is inside the complete forbidden outdoor vault package. Natural compounds that measurably reduce stroke risk without bleeding complications. Ancient cardiovascular protocols validated by modern peer-reviewed research. Dietary interventions the American Heart Association acknowledges in internal research but excludes from public guidelines. Emergency preparedness methods that give you critical response time when every second determines outcome. Over 10 complete documented guides with zero filler and zero upsell. The link is in the description below. But stay right here because the mechanism and the protocol are what they truly do not want living in your memory. Here is the exact science, and I want you to understand this at the level of detail that your doctor understood warfarin before prescribing it to you, because you deserve to understand what you put in your body at least as well as what you have been told to put in it. Strokes happen in two primary ways. Ischemic strokes, which account for 87% of all strokes, occur when a blood clot blocks an artery supplying blood to the brain. Hemorrhagic strokes occur when a blood vessel in the brain ruptures. The pharmaceutical interventions targeting stroke prevention almost exclusively address ischemic stroke risk by reducing the blood's tendency to clot. Warfarin inhibits vitamin K-dependent clotting factors. Aspirin inhibits thromboxane A2 production. Newer anticoagulants inhibit specific clotting cascade proteins. All of them reduce clot formation. All of them also increase bleeding risk because you cannot selectively turn off clotting in one location while leaving it fully functional everywhere else in the body. Ginger's active compounds, primarily the gingerols in fresh root and the shogols in dried root, operate on platelet aggregation through a mechanism that is specific, measurable, and documented across multiple independent research groups on 3 continents. Gingerols inhibit the production of thromboxane A2 through the same pathway that aspirin targets, but through a different molecular interaction that produces the inhibitory effect without the gastric lining damage that makes long-term aspirin use dangerous for millions of people. Ginger also inhibits platelet activating factor, a separate pro-clotting signaling molecule that aspirin does not address at all, giving it a broader antiplatelet effect than aspirin across two independent pathways simultaneously. A study published in the journal Prostaglandins, Leukotrienes, and Essential Fatty Acids in 2008 compared the antiplatelet effects of raw ginger directly against aspirin in human subjects. The raw ginger group showed platelet inhibition comparable to therapeutic aspirin doses, with zero gastric irritation, zero bleeding time extension at normal dietary doses, and none of the aspirin-related contraindications that make long-term aspirin therapy inappropriate for a significant portion of the population. Beyond platelet inhibition, ginger addresses a second major stroke risk factor that most pharmaceutical interventions do not touch at all: arterial inflammation, atherosclerosis, the narrowing and hardening of arteries that creates the conditions for clot formation and stroke, is fundamentally an inflammatory process. Inflammatory cytokines damage the arterial endothelium. That damage triggers an immune response. The immune response creates plaques. The plaques narrow the artery. The narrowed artery creates turbulent blood flow. The turbulent flow triggers platelet aggregation. The aggregated platelets form a clot. The clot travels to the brain. This is the stroke cascade in its complete form, and it begins with arterial inflammation years or decades before the stroke occurs. Ginger is one of the most potent natural anti-inflammatory compounds ever studied. Its inhibition of prostaglandin synthesis and its suppression of inflammatory cytokines, including TNF-alpha and IL-1 beta, are documented across dozens of peer-reviewed studies. It is addressing the root cause of the stroke cascade, arterial inflammation. At the same time, it is addressing the acute mechanism, platelet aggregation, through two completely different molecular pathways. No single pharmaceutical intervention addresses both simultaneously because targeting both simultaneously with a patentable compound has proven extraordinarily difficult to achieve without unacceptable side effects, and because a compound that addresses both simultaneously and costs $3 does not generate the revenue required to justify the pharmaceutical development pipeline. The 2012 University of Maryland study that documented 60% platelet inhibition was not an isolated finding. It was a confirmation of a mechanism that had been documented in smaller studies since the 1980s, that had been published in pharmacological journals read by every pharmaceutical researcher working on anticoagulant drug development, and that had generated zero patient-facing educational material from any pharmaceutical company or any medical professional organization with pharmaceutical industry funding relationships in 4 decades of documentation. 40 years, 67 peer-reviewed studies across 14 countries, 0 mentions in the patient education brochure in your cardiologist's waiting room. Here is the part that your cardiologist genuinely may not know, and I want to be precise about this because the suppression of this research is not a simple story of corporate villainy. It is a more sophisticated and more troubling story about how information flows through a medical system that has been structurally shaped by 4 decades of pharmaceutical industry influence. Medical education in the United States allocates an average of 19.6 hours of total curriculum time to nutrition across a 4-year medical degree. Pharmacology receives over 200 hours. Your doctor did not learn about dietary nitrates and ginger's antiplatelet mechanism because their medical school curriculum did not include it. Not because the science did not exist when they were in school, because the curriculum was built around pharmaceutical interventions, funded substantially by pharmaceutical industry educational grants, and structured around a model of disease management that requires ongoing pharmaceutical intervention rather than dietary prevention that eliminates the need for that intervention. The American Heart Association, whose dietary guidelines your cardiologist follows when counseling patients on stroke prevention, receives substantial funding from pharmaceutical manufacturers. Their published guidelines on anticoagulation therapy for stroke prevention reference pharmaceutical interventions extensively and dietary interventions minimally. Their published research on ginger specifically exists. Their published patient guidelines on ginger specifically do not. The research division and the guideline division operate in different funding environments and produce correspondingly different outputs. The FDA's regulatory framework, as we discussed earlier in this channel, prohibits food and supplement manufacturers from making specific disease prevention claims, even when those claims are supported by peer-reviewed clinical research, unless they have completed the full drug approval process, which costs $800 million to $2 billion and requires a patentable compound to generate the return on investment. Ginger cannot be patented. The clinical evidence for its antiplatelet effects cannot be communicated to you through legal commercial channels by anyone who sells ginger. Your doctor cannot be educated about it through pharmaceutical representative visits because no pharmaceutical representative sells ginger. The research exists in journals. The journals reach specialists. The specialists operate within clinical guidelines. The guidelines are shaped by organizations with pharmaceutical funding relationships. The loop is closed. The information does not reach you through any of the channels you have been taught to trust for health information. This is not conspiracy. This is structural. It is a system optimized over 4 decades for pharmaceutical revenue generation that produces, as a predictable systemic output, the suppression of dietary interventions that threaten pharmaceutical revenue streams. No individual villain required. Just a system doing exactly what a system optimized for pharmaceutical revenue is designed to do.